Okay, hi you guys. So going over the rest of this information, I'm just gonna try to go over some of this stuff um, throughout this lecture. So really, it's just kind of going over. I think the beautiful thing about going over some of this stuff is that once you know one of them, you can kind of understand the other one. It's just kind of thinking opposite for some of this stuff and kind of just thinking patho-wise what we're talking about again. So in terms of what you need to know for exams, it's kind of what we're just going over some of the lecture stuff, how I think about it and then some of the things you should know, some things to point out. But really, for the most part, it is also just kind of understanding the conditions. Because again, I would hate to just kind of be like, oh, you need to know this without explaining it. And then you kind of get to the final and you're like, oh, I don't really remember because I just kind of memorized everything. So same stuff that goes as last time. I kind of say this on every single time we meet, but basically for the most part, do not forget about the other stuff that we've been going over and things that you've gone over in class. So that includes like your ABG interpretations, your dysrhythmia interpretations, right? Your EKG things that your guys are doing, and then as well as the ABG to vent settings correlation, kind of how you do that with the PaO2, the FiO2 ratio. That's another thing with the Berlin criteria you want to keep in mind. And then there are other things that you guys have talked about, like the indirect versus direct treatments for hyperkalemia. So those things that you definitely want to keep in mind, just because again, you can still be tested over that stuff. And as we keep going into the rest of the semester, and you guys are almost done, which congratulations. But just keep that in mind, like especially when we talk about DKA with the anion gap, when we talk about the things for mods in terms of the order of what to learn about. You kind of just want to keep those things in the back of your mind because again, even though you guys are learning new information, it is stuff that you do have to know and do understand. Just because again, it'll come in handy for the final when you're restudying everything. You kind of are like instead of having to technically relearn everything, you just are relooking at it and you're like, oh yeah, that's right, we went over this. It's just kind of like a refresher, right? So, DKA, basically, just to kind of remember and talk about if you're not really understanding some of the stuff behind diabetes mellitus in terms of how that works. So, with type 1, remember they're not producing any type of insulin, right? Their pancreas is not producing any insulin. That's also the diabetes that we see more of, I guess, the skinnier people have those issues and younger people who have had those issues, whereas as type 2, you kind of see in older people and people who are more overweight or who have sedentary lifestyles. That's kind of debatable within like new research now, and they don't really like to call it that because it could be anybody who gets either or. But usually, I would say for the most part, that's kind of how we associated it. So at least for type 1, though, they kind of just have an autoimmune function with their pancreas that's going on where they're just not making any insulin at all, so they have to get insulin, right? Whereas with type 2, it's more of associated with like they're obese or they just aren't really exercising, they're not eating well, they're eating a lot of sugar. So those patients can be on something like metformin first, and then obviously, if they need the insulin, then they can get that as well. So just things to remember with insulin is that it acts as a key for that glucose to go into the cell, right? So if I'm checking my patient's blood sugar on glucometer, it's high, well, we can give insulin according to whatever order or protocols we have to follow. So we'll give the insulin, and then basically what that does is it's going to just, yep, act as a key. So the glucose that was now in the blood is now going inside of that cell. You check their blood sugar in a little bit, it's going to be lower because now it's inside that cell out of the blood. Pretty self-explanatory, but in terms of, I guess, manifestations, I think we've talked about this before, but the three Ps, polyuria, polydipsia, and polyphagia, right? Having to void a lot, feeling hungry, and then also feeling like you have to be thirsty. So other signs and symptoms are fatigue, weakness, nausea, abdominal pain, dehydration, headache, and muscle cramps. And then when we talk about DKA, it's the same symptoms essentially, but kind of just exacerbated. And in terms of education, we kind of talked about this before as well. We already know some of the lifestyle stuff they have to do. Their sick days in terms of what they have to do for insulin care. And then in terms of their foot care, because we have things like diabetic nephropathy, also affecting the eyes and other organs as well. And then kind of just talking about those things, just general stuff. You kind of already know that. In terms of now DKA, so diabetic ketoacidosis. So this is an absolute or relative insulin deficiency. It is more frequent than HHS, and I feel like you'll start seeing that, especially if you're working in an ICU setting. It's more DKA patients that you're looking at, but there's also a lower mortality with that as well. So more frequent, more common, but I guess less mortality. So, in terms of etiology, infections and acute illnesses, and I feel like you can kind of relate that to, when we talk about care plans a lot, I think the main like reason why a lot of the glucose is high is because of the body's stress response of what's going on, right? We say that a lot within our care plan. So I think it kind of also relates to this as well, knowing that infections and acute illnesses can exacerbate your blood sugar levels as well. And then also what's kind of going on with, your production of insulin and whether that's not being made at a really good rate or too fast or too much. And so basically another thing that you can see, and this makes sense, is insulin noncompliance and a new diagnosis of type 1 diabetes, right? Since they're not making any insulin, meaning that their blood sugar has a really high possibility of being, their blood sugar has a really possibility of being high, right? And then again, yeah, the non-compliance makes sense, and that usually is seen more within females, and I probably would attest to that because I feel like I've seen that more in clinic within that age group, which is kind of shocking, but at the same time, those are just some of the differences there. And then again, manifestations, basically, yeah, those exacerbated symptoms of DM that we talked about. So the three P's, those other things, and then again, fatigue, abdominal pain, dehydration, and that's because again, the intravascular is now becoming dry, hypotension, headache, altered level of consciousness, shock, and comas. And then again, those notes at the top are just notes I've taken before whenever I was studying this stuff. In terms of the biochemical problems, there's only three of them that you have to know. So this is kind of just thinking about how this is kind of created and kind of the etiology of like these things, right? So hyperglycemia, usually it can be around 600 plus or minus like 150. So basically the cause of hyperglycemia is, I can't ever say it correctly, but we have those different terms, glycogenesis, gluconeogenesis, and then glycogenolysis. I don't know how to say that word, but basically kind of going based off of what those things are. Well, glycogenesis, which is kind of easier to remember for me, but when you consume food, basically, especially those carbohydrates, right? Their glucose enters your bloodstream, and then your body technically doesn't need all that glucose immediately for energy, so it stores it as glycogen, right? And then it stores that glycogen in your liver, in your muscles, I think as well. But basically, that's the whole storage process there. With gluconeogenesis, that's kind of now talking about what happens when your body needs glucose, but there is no when your body needs glucose, but there is no like food derived glucose necessarily like available. So then that's the process why your body then synthesizes or makes kind of glucose, tries to get something from tries to get glucose from like non-carb sources, so like amino acids and stuff like that. Again, some things that you don't necessarily have to know, but I feel like it kind of breaks those things down. And then for the lysis one, I guess that term. So again, when your body needs the glucose, especially you know, between like your meals and everything, or like let's say if you're exercising and you're breaking like a lot of those sugars down or your cells need it, basically it breaks down that glycogen into glucose, and that's how we get. So those are terms like A and P, and I wrote some of that stuff down just to make sure I'm saying it right. But basically what we're talking about with DKA is now you have an increase of gluconeogenesis and the lysis one. So basically your body thinks that when there's a insufficient insulin, right, your body thinks that it's in a starving state almost. And so then it begins the gluconeogenesis. So it creates glucose from those non-carb sources like the amino acids. And then additionally, the lysis, breaking down the glycogen to make it into glucose. So then furthermore, you just have hyperglycemia. So because of the fact that you just have two different things, they're breaking down the glycogen, and then additionally, they're just breaking down non-carbs like amino acids into glucose. You just have too much glucose overall. So that's kind of what the things that we're seeing with that. In terms of ketonemia, that's how we get the keto part of DKA, which is what makes it different, right? Than just regular diabetes, and then again, in difference to like HHS. So the ketosis state, and I kind of would think about this almost like if you've ever heard anything like the keto diet, and eventually like their body gets in the ketosis state. So basically, in the absence of insulin, cells cannot use glucose for energy and are essentially starving. So kind of what I talked about. So the body then switches into breaking down fat stores for energy, right? So then that leads to the production of fatty acids. So these acids then are oxidized into ketones. So we can now see the ketones in like the urine, all of those things there. So basically, that's kind of the process of how it's happening. So basically, it's breaking down that fat for energy. Now you got fatty acids. Then those acids are then basically changed and oxidized into ketones. That's kind of some other stuff you have to know. But basically, if you just know this, fat broken down, then they're made into ketones eventually. So essentially, you can see the two ketones, basically serum acetone and then the B-hydroxy. So those are the two ones that you definitely need to know and understand. In terms of these three biochemical problems, you should know this kind of like, okay, hyperglycemia, ketonemia, and then what goes underneath that? Well, the acetone and the B-hydroxy, right? And then the third one is this the high anion gap. So that's how we know that it's metabolic acidosis with DKA. And so the anion gap is the difference between like positive and negative ions. And this kind of goes back to chemistry, how you want it equal within both like sides of the like equation and everything. So basically the normal formula of what you need to know to calculate is straight up what it is. So this is without potassium for the first part. So it's the sodium, and then minus in parentheses the chloride with the bicarb. And then usually the normal for that is less than or equal to 12. So that's the first thing you need to understand. You need to technically memorize. So I would recommend to just write it out until you get it. And so one thing to note is that CO2 and bicarb are um, interchangeable, right? Because that's what's in the hospital. You also see that they call the CO2 their bicarb as well, some of the time. So at least just understand those things and know that if you're like, oh wait, I wasn't given like a bicarb. If you're giving the CO2, that is the bicarb. So basically, the formula used to calculate if there is a potassium, then it's all you're going to do is then again the chloride's going to be with the bicarb, and then or also it could be technically CO2, which is also your bicarb, and then sodium plus the potassium is going to be together, and then again the chloride plus the bicarb. So you have those things, and then you're going to subtract that. So basically that's what it is. That's the equation there. But the difference between that, if it has potassium, is that it's less than or equal to 16. So 12 and then 16, 16 specifically with the potassium. Potassium is going to be with the sodium, and then the chloride and the bicarb are going to be together there. So really, I feel like you only have to memorize one of the equations and just remember the next part. You're just going to add the sodium to the potassium. Sorry, the sodium to the potassium. Yeah, the potassium to the sodium. There you go. So then after that, basically it's just knowing like in a metabolic acidosis state, the anion gap can either be normal or it could be increased, but that basically helps to determine the cause and they're guiding their treatment, especially when they're talking about treating a patient with DKA and everything there. So kind of just to read about more on the patho, I would recommend to kind of read about it. It kind of talks about what I said earlier, so you can kind of read that and see how that kind of correlates. This is just a whole paragraph that I needed to put in because at the time I was like, okay. But essentially, this is kind of what I talked about earlier with the differences between gluconeogenesis and the lysis one, because again, those are two different ways that you're having those hyperglycemia effects there. In terms of the labs, I feel like this is kind of, again, just going into everything we talked about. So I'm not going to go over it, but it does make sense. Again, like you're going to see that anion gap, the electrolytes imbalance, ABG disturbances, the B-hydroxy and the acetone, obviously, with the ketonemia. Your glucose is going to be around that 600 mark. You can see the glucose within, your urine, the ketones. And then same thing with your cultures. You want to look out for wounds, anything like that. And so diagnostics is the same thing, right? So the 12 lead, if you want to see some of, if we're having like electrolyte imbalances, as well as just any type of dysrhythmias, checks X-ray, KUBs, so CTs, MRIs. I feel like for this part, I wouldn't even necessarily need to know that. I don't think you would have to. It's just everything we talked about. Again, you're just wanting to look at the biochemical problems, and then really the treatment with that. So if you know this top part as well as the equations, you're all set. And if you can explain that to me and just be like, oh yeah, hyperglycemia because of these two things, ketonemia because the fatty acids were broken down, oxidized into ketones. The two ones were acetone and B-hydroxy, and now the third one is just we're in metabolic acidotic state. So now for our anion gap, that's kind of how we're measuring and seeing what's going on in terms of what's happening within our positive and negative ions, and kind of that, again, that acidotic state, well, you can look at it with the sodium chloride, the bicarb within the equation. With the potassium, it's 16. Without, it's um, less than or equal to 12. If not, potassium less than or equal to 16. So treatment. So this kind of, again, things that we talked about. Basically, same things. Hydration, IV. That's the first thing that we're going to do because, again, keep in mind that they are dehydrated. So we're going to give normal saline, and then the rate, again, that depends on what their blood pressure is and what comorbidities they have, but additionally, and then usually around 150 to 200 an hour, mLs per hour. And then again, if the patient gets hypoglycemic, so you can administer insulin to counteract, but you also need to change the NS to basically D5NS. So basically, then when the glucose hits 250, that's when you'll do that. So fluid glucose, so basically you're sitting at like the 600s, right? So you'll be starting them on NS for like 150 to 200 an hour. Okay, you keep them, you're probably going to have them on an insulin drip. We're going to start with a regular like insulin, so 10 to 15 unit bolus, but then it's going to then become a drip, and then you learn how to titrate that, but that's according to your order. Do you have to know that? No. But you know that you titrate that just like how you do it with your drips for your vasopressors. So like with your Levo, like you're looking at the map above 65, okay, it's at 55, then you're going to increase, right? So it's the same exact thing with insulin, but basically what you're doing is that you're going to give the bolus first for 10 to 15 units, and then you're going to start the drip based on, again, that protocol. So after, you're going to keep checking their insulin, right? To whatever your order says, but you're going to keep checking that insulin because you want to make sure that you're not decreasing it too fast, and then or not your insulin, your glucose too fast, but you'll keep checking that blood sugar, because, and we'll talk about it in a second, but you keep checking it, and so eventually you're going to get down to like 250 for your blood glucose. If that's the At that point, you're going to change the NS to D5NS, is basically what we're saying here. Just because, again, now they're at risk of becoming hypoglycemic, and then we're wanting to make sure that, hey, we are giving them insulin, but at the same time, we're not causing them to be affected really quick. So regular insulin IV, yep, so basically 10 to 15 units bolus, then drip, and again, that's based on the protocol, and it is based off of also like what weight we're looking at as well for the patient. Hourly finger sticks while they are on that insulin drip, so there you go, that's where you see that at. And then they will continue basically until the acetone, the ketones, and the hydroxy are basically negative. And then some hospitals, they also like look at the anion gap for that as well. And so basically one thing is you can probably switch it to sub-Q insulin once the B-hydroxy is negative, but it has to be negative twice, right? So you'll see those things there. So basically all of the things you have to know to kind of sum is, okay, you're going to start them on NS. Once they get to 250, then you switch them to D5. Okay, you'll also simultaneously give them a 10 to 15 unit bolus, then you'll do a drip of insulin. You're going to keep checking the blood sugar every single hour, and then basically you're going to keep doing that until their B-hydroxy, acetone, and ketones are negative, and then eventually you can convert that as well if the B-hydroxy is negative times 2. So that's what we're seeing there. So again, looking at that blood sugar, you're looking at that every hour. So let's say 1 hour it's like let's do like it's 400, okay, and now you're checking it an hour later and you're at like 290. Well, now you decrease their blood sugar more than 100 in 1 hour, so you have to slow the insulin rate, because again, the reason for that is because you have a risk of cerebral edema. And again, when we're talking about like fluid shifting, we're talking about sugar, we know that like the fluid will follow and water will follow that sugar, kind of like how it follows salt. So again, we want to have the decreased risk for cerebral edema, and because of that, you're going to give that blood glucose, or you're going to slow the insulin rate to make sure your blood glucose is not increasing or decreasing decreasing too quickly for that. So again, everything that you have to know there, that's kind of those things you have to know. Other treatments you can see there. Additionally, one thing to know, so obviously we talked about indirect and direct treatments for hyperkalemia. So with your insulin, you're going to give the insulin, right? But your potassium also follows into that, into the cell just with the glucose. So then you're at risk of also having hypokalemia. So you want to check out for those risk factors as well. And I wouldn't be surprised if that's something, we talk about it, electrolyte imbalances, and this is definitely one of those things that you're checking as well. And that also goes into the anion gap of, checking for, the potassium in our acid state and everything. But more specifically, just that's another thing to note. But really, again, kind of with the treatment, this is kind of what you're looking at. So 150 to 200 for the normal saline, and then D5NS once the blood glucose hits 250. Insulin, you bolus 10 to 15, then you start them on a drip. Q whenever, finger sticks, and then again, do it until those things are negative, and then once it's negative times 2, you can go to sub-Q. And then, yeah, watch for cerebral edema. Only blood glucose can be 100. If it's 101, you gotta slow the insulin rate, right? So, in terms of HHS, so hyperglycemic hyperosmolar state. So it's defined by hyperglycemia, and again, increased production, decreased use from the cells, right? So we're increasing our production of glucose, but then our cells aren't using it, right? So that also adds on top of to that the dehydration. So all of them have dehydration with that, right? So diabetes, dehydration, DK, dehydration, HHS, dehydration. But what's the difference is that, well, there's no ketosis with this, right? So this also leads to hyperosmolality, right? So there's a higher mortality than DKA. That's the other difference. DKA more common, but less mortality with that. So causes inadequate insulin, makes sense. Major illness and infection, same thing as the other one. And then new onset type 2 diabetes. So those are the difference there. And then medication non-compliance, plus comorbidities like the hypertension, thyroid, PSH, etc. But basically things to kind of know: insulin, infection, illness, same things as last time. Difference is that this one has more common within type 2, the other one is more common within type 1. For manifestations, early polyuria, polydipsia, same thing. And then altered mental status is the other one with this one. So basically, when we're talking about labs, the difference is now your blood glucose could be 800, give or take, and then the big thing with this is like you're just dry. So obviously with DK you're dry as well, but really the thing with this is you're even more dehydrated. So your intravascular, intracellular are just dry. Your serum osmolality is above 320, which is also, she kind of explains it, is 3 times your sodium level as well. So if you forget, just you could also remember, well, your sodium, it's just going to be 3 times from that, so 320. Your anion gap is actually going to be less than or equal to 12 usually, and then for your ABGs, your pH, it could be above or equal to 7.3. So you're not necessarily acidotic, but you're not acidotic, but not enough to necessarily control your glucose either. And then your bicarb could have a normal or slight elevation. So again, you don't see the same things that you saw with DKA, right? You saw the anion gap with the metabolic acidosis. So those are the differences that you can see. Whereas with hyperglycemic hyperosmolar state, that's just more leading to severe dehydration and the hyperglycemia. Whereas DKA, you're in a ketosis state because of those fatty acids being oxidized, right? And then additionally, you're still in the hyperglycemia state. And then also you have the metabolic acidosis with that whole anion gap. Whereas with this one, it's more about just dehydration and the osmolality, right? And then the glucose, is actually a lot higher, like at 800. So same thing, 12 lead, checks X-ray, all the same things. For treatments, so same exact thing. You're going to give normal saline, right? So we're not changing that. So judicious hydration, that's the thing, because remember, keep in mind, this one's the one that you are dehydrated. So you are going to do 1 liter in 1 hour, which is a lot different than us doing 150 to 200 mLs per hour, right? So 1 liter, so 1,000 mLs per hour. And then, or you could do 0.45 normal saline, but it also just depends on your sodium level. But most of the time, I feel like it was just you pick the NS, right? And then also your hydration depends on your cardiovascular, BP status, renal status, because again, you could be giving those things, but we have to check what's going on with that first, as well, or keep those things in mind. But again, normal saline, 0.9, 0.45, but you're trying to hydrate them as much as possible. In terms of for potassium replacement, that's another thing. You can only give this if it's less than 3.3, right? So you must give it also before the insulin, because keep in mind, if I give the insulin, well, the potassium is going to go in with the insulin. So it would make sense to give the replacement before and not like during or after, because that's a little, you would have to give a little bit more because you just gave the insulin. So do it before. So again, only if it's below the 3.3. And then again, electrolyte replacement PRN. So anything like the potassium, other electrolytes that you see there. And then again, you have the insulin as well. That's an IV. It's per the protocol. And remember, it lowers your potassium. So that's kind of what I was talking with DKA, but really you're kind of doing it more with HHS. And that has to deal with a lot of the changes that you're seeing here with our fluid status and dehydration. So complications, you can kind of read about those. But basically, in a sense, for HHS, the difference is that your glucose is higher at 800. You're seeing it more likely in type 2 diabetes patients. Your serum osmolality, which is also showing you that you're super dehydrated, so it's going to be above 320, which is also 3 times the sodium. Other things, well, it's going to be same thing, NS, but you also can give 0.45 if it depends on the sodium level, and then you want to worry about potassium more, and you also want to give electrolytes, and then again, insulin IV per the protocol as well. So those are the things there. So just kind of, they're almost the same, except for the kind of patho of it, and that it kind of also explains why we do these specific interventions that we do, and the differences there. So I guess education for both of these patients and for also just general diabetes patients. If a patient has an infection, right? Remember, those are both the risks. You should be knowing if they have an infection and they have diabetes. Basically, DKA and HHS should be on the radar, right? Because again, there's a risk of infection for both of those. There's a risk of both of those things to happen if they have infections, right? So communications between units with patient transfer, and that also is super important, especially when you're starting them on insulin drips, when you're starting them on IV fluids, when you're starting to look at their labs and especially their electrolytes, and also if their like the hydroxy or acetones are negative and everything. So again, you're seeing that more with DKA, but things to like look out for HHS, the potassium, those things. Um, One thing to kind of know, and I kind of would agree on this last point. When I started work, I had a DKA patient, and it some of the patho stuff I was like, oh, this makes sense why we're doing this. So, and it goes back to like learning this stuff. But one of the things that's super interesting is when you're getting a newly admit patient. We got a newly DKA patient from the ER, and we didn't know if they started them on the insulin drips or they had the med there, but we don't know if they started it. We asked the patient. Obviously, they're not going to know um, everything of what's going on. So we kind of had to, talk to the doctor. Doctor says, okay, well, let's just act like we're starting it, and then we'll see what's going on. Blood sugar was like 500, 200, 68. There was a lot of different things that happened. So again, that's why you check their blood sugar frequently or per their like protocol. At least for us right now in this setting, you check it every hour for that DKA, and then again, really both of them NS. We throughout this entire semester we're going to be basically giving NS, and then once we talk about neuro, we'll be doing some other stuff. But pretty much NS. And then, yeah, you worry about your potassium replacement, your insulin, and we talk about those things. So just write it out. And once you know those things, you have every single thing. So it's not like you have to memorize all of this stuff. It's really just that, the treatment, and then that. And once you say it out loud and write it a couple of times, you'll be like, oh, yeah, I got that. That's pretty good. And then when we talk about DI, SIADH, it's going to be the same exact stuff. So, but you only need to memorize one of those and think about the opposite. This is kind of just, you can't really think about the opposite. You just have to like let out or change and switch out a couple of things. Because with this, you don't have ketotic state, a keto state, right? So HHS, no keto, DKA has keto. So it's in the name, but that's kind of how I think about those, at least for that. In terms of this information, so I don't know if you guys are going over heparin-induced thrombocytopenia, but I'm going to go ahead, at least we can go over DI and SIADH tomorrow or some other time and all of that stuff. I feel like for the organ transplant, we didn't really get tested over it. I feel like I like studied it and like we didn't even get tested over it, so I kind of was like, what? And then same thing with the drug-resistant infections. I feel like the only thing we have to really talk about is kind of the how do those bugs and bacteria get resistance. Um, but in terms of like the meds and stuff here, I didn't memorize those things and I was fine and they didn't at least Manuela didn't ask us about it, but at the same time, anything's fair game, so we can at least talk about it, at least have somebody go over it with you, but I'm really just gonna be reading it, I feel like. But at least for this stuff, I feel like that's the most important things to understand. And then organ transplant, I feel like she doesn't really test you over these things. I remember they were on the final, but I think it's also because we talked about organ transplant at our very last lecture because we had someone from One Legacy come, so it was more of those things to understand. But again, you should at least kind of look at some of this stuff. But at least for today, wise, we'll just talk about mods to kind of end it, and then we can go to heparin and everything. I'm like debating about it whether I should just do it now. It's really not too bad as well, but I think um, we'll see how it goes. But in terms of mods, so we kind of talked about sepsis. So obviously we talked about ARD, sepsis, DIC. We'll probably have to get to, and I think DIC was another one that we learned about as well. But at least for mods, progressive dysfunction basically are two or more organ systems because again, that lack of perfusion, all of this third spacing, all of this fluids going away with the increased capillary permeability, and then basically you have an uncontrolled inflammatory response. So everything's going crazy, chronic organ failure, basically death. Once you get to mods, the mortality is pretty increasing pretty fast. One organ is 12%, two organs 40, three or more organs 60, and then three or more organ systems for more than 4 days 100%. So your overall mortality for mods is around 50%, and that is something to kind of be aware of because your mortality rate is kind of high, and you want to be realistic when we're talking about the outcomes for this patient. So in terms of the order of presentation, you kind of just have to straight up memorize this, but also I feel like it sort of makes sense in some way. To me, it makes sense because your pulmonary system is always going to be the one that's affected. That you can definitely see in terms of a lot of the compensation stuff. So once you see the PaO2s below that 80, that is your indication for pulmonary being the first. And also on a question, it will always be the first. So if she were to ask you what's the first system that's affected, you are going to say, well, the PaO2 is less than 80. That's usually the first thing that you're going to see. So if they were to give you options like, okay, the PT is like this, the INR is like this, BUN is super high at this. It's like, well, what's the first order of presentation you're going to look at? It's going to be the PaO2 below that 80, right? So that's going to be your first. For your coags, basically what we're talking about is your PT, your PTT, and your INR. So I kind of wrote the values there. You could double check them. For PT, 11 to 13.5, PTT 20 to 30, and then INR 0.9 to 1.1. I think we had to ask for the values because a lot of the time in NCLEX World, they give you the values as well. So you don't necessarily have to memorize them. But again, I don't think we had them for this exam. I think we had it maybe for the final. But regardless, it's pretty easy to pick out. And you can see it, but if I also just kind of memorize it for the time being. The next things you're going to see are your BUN, so your BUN like 5 to 25 or 6 to 24, creatinine like 0.6 or 0.5 to like 1.3, hepatic, so your LFTs, intestinal, neurological, CV system. So those are just the order. That's just the order that you're going to see it. And then usually you just have to remember how it kind of goes. And I just would write it out like pulmonary, coags, renal. I wish I had something to kind of help you guys like remember it. But really, I just was like, okay, pulmonary, coag, renal, hepatic, intestinal, neuro, CV. So that's just kind of how I just wrote it out like 50 times. And I was like, okay, I got this. Like, there's no way. And then, before you're answering the question, write it all out. You know that the PaO2 is going to be your first one. So management of mods, it's really just preventing this from happening because once you get it, it's at this point, like, what are you going to do for the pulmonary? Well, you're going to try to do everything you can respiratory wise. You have them on a vent, you do all these things, but at that point, we're already getting to that mortality rate where it's not, you can't go back, right? And you could, it could, but it's just a lot of that time, realistically, that mortality rate is really high. So what can we do to prevent that? well, all of those things that we talked about with sepsis, right? Preventing those things from happening, and we can do things like our sepsis bundle to, lead a patient to be properly perfusing, making sure that their organs are being, properly oxygenated and perfused. So, yep, basically it's directed to maintain their BP and MAP because that's the whole entire point of what's going on with sepsis. And then with the infection, intravascular volume restoration, adequate tissue oxygenation, and supporting just the organ dysfunction, or organ function, pulmonary, you put them on a vent, renal, you can start them on dialysis, things like that. But again, those things you do have to have conversations with the family about being like, okay, is this what the patient wants? All these different things. So prevent that from happening in the first place. And that's why we have things like our pressors. That's why we have things like giving our, let's fix the cause of the infection in the first place. And that's why you see things like, okay, like let's look at our CVP, let's look at these hemodynamic parameters by looking at like arterial lines, CVP lines, anything that the doctor decides that they want to insert so we can look more at their fluid status. And that's just overall volume, overall perfusion, right? For heparin-induced thrombocytopenia, I think we can go through that tomorrow because I feel like for the most part it's pretty straightforward. DI, I feel like once you go through one of them, the other one is pretty much the same exact thing. The only difference is maybe just the medications and understanding that. Um, and then yeah, I guess the other stuff as well, but really it's just a couple of things. And then in terms of neuro, I do know that for us, she went over some neuro stuff, but it was just like assessment stuff wise, but it wasn't anything too bad. So I'm going to stop the recording here. And then for the rest of the stuff, we'll be going over the hit, and then the rest of these things as well. And yeah, other than that, I think DIC, I'm like, did we over DIC already? But I'll have to look at the other ones. But yeah, so I'll just stop this recording so it's not too long, and then you split that up as well.